This is Dr. Banerjee, welcoming you all to the XLPAD webcast today on July 10th, 2014. Today's presentation is on crossing lower extremity peripheral CTOs using OCT. I think, and this presentation is going to be made by Dr. Ian Cawich from Arkansas Heart Medical Center in Arkansas, in Little Rock, Arkansas. Dr. Ian Cawich is an extremely experienced peripheral interventionalist who has received most of his training at the University of Arkansas Medical Science Center, and then went on to receive his internal medicine and interventional cardiology fellowship training at the same institution, and went and then joined Arkansas Heart Hospital and Clinics, where he is an interventional cardiologist with about over 40% of his overall volume dedicated to peripheral interventions. So we are really looking forward to some exciting cases and didactic discussions from him today. Just to mention that Dr. Cawich is extremely experienced and is a trainer and a proctor of training physicians around the country in the Avinger's Ocelot OCT device use, and I think we have in store some great information and possibly a phenomenal case using the applications of this technology. As always, this is a fairly informal discussion. I will be moderating this discussion. The format today would be a few didactic take-home points from Dr. Cawich, after which I will ask him a few questions. You're welcome to ask some guiding follow-up questions after the short didactic content. And after the didactic content is over, we'll launch into the actual case that Dr. Cawich will walk us through, following which we'll again have a brief Q&A session. You want to start on time and end on time. I also request you, when you are not speaking, please mute your line so that we can minimize the disturbance. With that, I'll hand it over to Dr. Cawich and mute my line, and then come back again after the didactic content is presented. Dr. Cawich, take it away, please.
Thank you so much, Dr. Banerjee. Welcome, everybody, this morning. Hopefully we can have a vivid discussion on the use of a rather new application that is exciting. So we're actually going to be talking about an extremely long peripheral CTO that we were able to use across using multiple techniques, but for the most part it was using the Ocelot OCT guidance. Full disclosure for this talk is I'm a consultant for Avinger and Abbott. So when it comes to CTO crossings, there are two main ways of which we approach crossing peripheral CTOs. The most common and most of the time successful ways is using a support catheter and wire technique. There are multiple support catheters in different sizes and different lengths, made by different companies, each having their own specific flavor. Some are not tapered, some are braided, some are angled. These allow us to then use either a 035 glide wire or glide advantage, and most recently now we're having also specialty CTO wires. The most common brand are the Asahi wires with the regalia, the Treasure 12, Treasure Floppy, Starter 20, and Starter 30. Those are all going up in gram tip strength. The other option of approaching a CTO is using a dedicated crossing device, of which there are now several on the market. The crosser uses microbubbles to cause vibrational energy onto the CTO cap, including CTO. The front runner is more of a blunt edge dissection. The TruePad uses diamond tip to drill through the CTO. We also have the Vions, which is also a small blunt tip catheter, not uncommon like the Crossboss in the coronaries. The Wildcat is also a blunt tip device which has spiral flutes. It allows for manual torquing and angulation. And the Ocelot, which is similar to a Wildcat, but different in that the flutes are not as aggressive, and there is an OCT guidance to the dissection or to the crossing catheter. In any event which, in failing to cross a CTO directly, we also have reentry devices which the Outback or Pioneer and Stingray are the most common options seen in most labs, which allow us to re-enter the distal lumen and have a successful case. Two strategies for crossing CTOs. The first is the subintimal navigation, which is usually involved with prolapsing a wire. Most commonly is using a glide wire, and this is well-characterized historical technique. Often sometimes you'll need a bailout with a reentry device at the distal end, and crossing subintimal does limit your choices for adjunctive devices, such as some atherectomy devices. The central luminal navigation would seem to be the clinical preferred strategy because it allows you to use whatever therapeutic option that you desire. A lot of these atherectomy devices are made to operate in the arterial lumen, so this would seem to be more favorable. The landscape for CTO crossing devices is, like I said, there are several flavors on the market now. Each has a clinical study for indication. We were actually a part of the Ocelot Connect 2, which is what I'll be speaking on. So the difference between using OCT and IVUS in the periphery is that with IVUS you can actually visualize well through blood. There's no interference from the blood in allowing you to look at the arterial structure. Using OCT, we have to be able to clear or flush the blood per se to allow us to visualize. This does lead the technology to work well in chronic total occlusions, because there's no blood flow in the chronic total occlusion, so your visualization is very good. The resolution of OCT is about 10 times that of IVUS, being able to see 10 to 20 micron resolution, versus with IVUS, the resolution is about 100 to 300 microns. The depth penetration for OCT is only 2 to 3 millimeters, so it we are limited in the vessel sizes, although we have seen we are able to use it in the iliacs and then all the way down to the below the knee vessels. The IVUS does allow us to have good vessel penetration, so 5 to 7 millimeters depth. In using the OCT approach, we use the Ocelot catheter from Avinger, and what this allows us here is to see that there are spiral flutes at the distal end of the catheter, and there 1 millimeter from the tip is a OCT imaging device. There's a fiber running through the catheter. This allows us to see the actual inside the vessel while we're advancing the catheter. And what we look for are layered structures. We see a definite structure to the arterial wall with the intima, the media, and the external elastic lamina, which is what we want to stay inside the vessel. Anything outside would be the adventitia and obviously any extravascular structures. Again, when we're looking at these OCT images, we can see that we want to position ourselves where to identify the layers of the vascular wall structure. We can also identify other markers while we're crossing, such as what we've come to define as cat ears, which is where the atheroma is actually peeling away from the vascular wall due to the blunt dissection of the catheter. We can here identify that we want to stay away from the layered structures and would position our catheter, which has a small deflection, away from the normal layered structures of the arterial wall into the non-layered or atheromal structures of the occlusion. Here would be a schematic of how the device would advance down the vessel. We would identify the layered structures in the vessel and the non-layered structures, and we would position the middle marker, which would position the catheter to point away from the layered structures. We would then advance the catheter until we were able to redefine where our structures are. At this point, if we were to advance the catheter, we would advance into the vascular wall and push us into being subintimal or intramedial. So at this point, we would stop and we would rotate the catheter to position the middle marker over the layered structures, and then again advance the catheter. And this way, we are able to advance through the chronic total occlusion without leaving the luminal space and cross the entire chronic total occlusion. The catheter was studied using in the Connect 2 study, which we were a part of. This was done in 2012. Well, a couple of points that came out of this study were that experience matters. Whenever we looked at the highest enrollers for the study versus the centers that had smaller enrollment, we noticed that standalone crossing was just using the device was better. So once our operators got to 15 cases, we noticed that the crossing with just the catheter itself was about 84%, 85%. That's without using any reentry device or any other wire techniques. That was just using from proximal cap to distal cap using the Ocelot device. We also noticed that the CTO crossing time improved whenever we were able to, again with experience, our crossing times, the mean average for the study was 33, but again for the more experienced patients, once they obtained a lot of Ocelot experience, the crossing time decreased significantly. What importantly this also allowed us to do was cut back on the fluoroscopy. So again, we were originally at a mean of 39 minutes, which with the highest enrollers we were able to cut down on the average fluoroscopy time. This is actually something that we noticed during the entire trial, and even now as one of the points is that the more you start crossing the CTOs using the OCT guidance, the more you'll pay attention to the OCT screen, and the more you will be able to stay off the fluoro pedal. A lot of times we've noticed that we're stepping on the fluoro pedal without even paying attention to the fluoroscopy and just paying attention to the OCT image. A couple of images to become familiar with when doing OCT cases is to identify what the proximal cap looks like. In this segment, you'll see that the entire catheter is surrounded by this concentric bright signal that almost looks fibrotic. This is the proximal classic characterization of the proximal cap. It's difficult to identify any layer structures in this segment. We all know the proximal cap is very fibrotic. Once we cross the proximal cap into the body of the CTO, we're then able to identify these layer structures that we're looking for. We're always looking for markers in the vessel that allow us to tell us where we are. Of these markers, the most important are the layered structures, followed by the external elastic lamina, or what's been classified as the black line. It's what we see often when you do histological staining. That would be the outer border of the media. After those, we would then also look for cat ears, which we've mentioned previously would be the tearing of the atheroma. Having the cat ears point away from you would also indicate to you that your positioning is well for you to advance the catheter. Once in this picture, you could see that after we've crossed the proximal cap, our middle marker here is pointing towards the layered structures, which would mean that we would be pushing into the arterial wall and more likely in the subintimal, and would then, which we would be able to identify in the OCT, but would then we'd have to either advance all the way through subintimal or pull back and redirect our catheter to allow us to stay intraluminal. So here we would rotate the catheter over to position this middle marker over the layered structures, such as in this picture here. Now our middle marker is over the layered structures, and so we would be able to advance the catheter staying intraluminal as we would be pointed into the non-layered atheroma structures. Once we arrive to the distal cap, again, we see that there is a bright concentric appearance around the catheter, and often we can identify the true lumen of the distal cap, which again here the positioning is towards the true lumen and away from the layered structures, and allows us to re-enter into the distal segment of the vessel that is patent. Once you cross the distal cap into the true lumen, where the vessel has reconstituted, you will see what we call a starburst, which is a rapid infusion of blood that washes away the saline that had been at the tip of the catheter. This produces what's called a starburst appearance and allows you to identify that you've crossed the vessel, crossed the distal cap, and are now intraluminal distally. At this point, you can advance your wire, your 014 wire, through the catheter and place it into distally. Alternatively, you can advance the catheter some more, withdraw the wire, and inject through the catheter to confirm that you are in the distal placement. Do we have any questions at this point?
Very good. Dr. Cawich, in the interest of time, let's jump straight to the case. Fantastic presentation. Okay. To be honest, we are very new to this technology, so thank you for laying it out in such great detail.
No problem. This gentleman was actually an 80-year-old male with a history of coronary disease and carotid artery disease, who had previously had peripheral work done. He presented because of worsening leg pain and discoloration, had been complaining of frequent pain and numbness in both legs, with redness in his left lower leg that had worsened over the past several months, and described a case where he had 3 of his toes that would look like they turned black in return to a grayish color. He had a history of peripheral vascular disease 4 years ago with a fempop in his left leg. He had been seen by his surgeon at home and was refused care, and he was refused surgery. He also had a second opinion more locally in Little Rock, who also declined any kind of intervention. When we saw him, his ABIs were 0.39 on the DPA and 0.47 on the PTA. He was actually in so much pain that he could not do a walking ABI test, which was not necessary, but he was having so much pain from his critical limb ischemia. I had our surgeon look at him, and he also felt that there was no viable surgical option for him. Here we do a couple of points that we had was that we had on the right a completely occluded common iliac stent that had been placed from the ostium of the right common iliac all the way into the distal segment of the right common femoral artery, done by an outside facility. So our only option was to go antegrade on the left side. Here we see that we have a sheet. We have a 5x10 sheet that was placed in the antegrade position in the left common femoral, and we see on the runoff that there is no superficial femoral artery. There is no popliteal artery. There is a profunda that supplies collaterals and a large genetic collateral to a perineal artery. The perineal artery then runs all the way down to just above the ankle and forms a collateral to the posterior tibial artery, which then supplies the foot. So this essentially is a chronic total occlusion all the way from the ankle to the hip, with the complete occlusion of the posterior tibial artery, popliteal artery, and a superficial femoral artery. We elected at this point, given the location, we were either deciding on antegrade or versus retrograde approach to the CPO. We took a LAO 45 degree angulation angiogram, and here you'll notice that at the SFA, at the common femoral artery, there are 2 areas that are visible. This is the old femoral graft, femoral popliteal graft, and this would be the true SFA. Again, due to the short nature of the common femoral artery, we elected not to become antegrade. This left us with a retrograde approach. We were able to, using the Cook pedal axis kit and ultrasound, access the distal posterior tibial artery below the ankle. I was able to pass a regalia wire all the way up to the just below the tibioperineal trunk. At this point, the regalia wire would not advance, so I was able to take a support catheter, a Cook CXI support catheter, which was fit through the 4 French sheet, pedal sheet. I was then able to cross the remainder of the chronic total occlusion in the posterior tibial artery. I was then removed the wire and injected through the catheter to confirm that I was my placement. And here we could see filling of the perineal artery and a small segment of the posterior tibial of the tibioperineal trunk. At this point, I knew that I was intraluminal in that segment. I then placed the wire and exchanged my sheet to a 5 French terumo slender sheet, which is actually a very interesting sheet that is a 5 French outer diameter, but the inside allows for 6 French passage of 6 French devices. At this time, we then took a Ocelot catheter, and we were able to position this in the at the tibioperineal trunk. Distal CTO cap. At this segment, we were then able to image that we were inside the distal cap, and we could see this concentric appearance around the catheter that we had previously mentioned. At this point, we advanced the catheter, and we were able to see our 3 layers. We were then able, visualize our 3 layers, advance the Ocelot catheter all the way up. This is the location of the previous anastomosis site for the graft, and if we look at the appearance here, we can see that there is a visualization of a space right behind the catheter. Again, we pointed away from that space to allow us not to go into the graft, but rather to continue into the lumen. We do see some layering of this segment, so I think our position is well. We continue to advance the catheter. The entire time being able to identify vascular structures, knowing that we're intraluminal. At the segment proximal to the cap here, we do not visualize, we cannot appreciate much calcium on the fluoroscopy, but we can see calcified nodules on the OCT. So as we know, fluoroscopy is very poor predictor for identifier of calcium in the vessels. We could see that the course for the catheter is well towards the ostium of the SFA. We then were able to arrive to the proximal cap. Again, we knew we were intravascular using the OCT. We were able to know that we were intravascular throughout the entire segment. At this point, we could not cross the proximal cap due to the fibrosis and the entire length of the catheter that was in the body. We tried to initially advance the catheter. We tried to also take a wire to see the wire. However, here you can see that the regalia wire wants to go subintimally into the common femoral artery. We also tried with the support catheter. We also tried with the Ocelot catheter. However, you can see here that the Ocelot catheter wants to go subintimally. We can also identify this on the OCT image of the Ocelot catheter. At this point, I was able to place a J-wire down into the profunda and upsized to a 7x10 sheet. I then took a glide advantage wire and prolapsed it into the ostium of where the SFA would be. I then pulled back the Ocelot catheter, and the glide advantage was able to cross the flap that was remaining, separating the true lumen from the reconstituted SFA. At this point, then I was able to just pull back the Ocelot catheter and follow it down with the glide wire. Due to the track that the Ocelot catheter had made, the Ocelot catheter makes about a 2 millimeter channel. The glide wire just trailed straight down behind, chasing the Ocelot catheter I was pulling back. I then was able to balloon with a 6x100 balloon, and then I then took my regalia wire from below and able to advance it up from a retrograde fashion. At this point, I ballooned the entire SFA segment. I had previously ballooned the posterior tibial artery with a 2.5 by 200 balloon. I then was able to, once I had my wire placed from the retrograde fashion, deploy a 5 by 100 superior at the distal cap, and here we see the ostium of the profunda and the ostium of the SFA with the superior placement. We were then able to place that 5 by 100 superior. We also placed another 5 by 100 superior at the distal end of the at the distal anastomosis site for the prior graft, as I felt that this was the other segment that would reach the nose if left untreated. Here we see the final runoff with good runoff down to the, on this view, to the popliteal artery, and then a more selective popliteal runoff down into the perineal and now the posterior tibial artery. So at this point, everything was removed. We saw the patient in follow-up 1 month later. His ABIs were 1 at that time, and his symptoms had resolved in his left lower leg. He was very grateful and requested that we proceed immediately to his right lower extremity. Do you have any questions?
Thank you for this wonderful presentation.
I want to ask you a question, which is pretty. You made a comment earlier in the presentation that if you are subintimal and you are able to direct this catheter away from the layered structures, do you actually mean that even if we are subintimal, atherectomy could be conducted if it is guided by this catheter?
No, I don't. I think that if for crossing purposes you're able to re-enter, so if you can identify the true lumen, you're able to advance the catheter back into the true lumen and allow you to then continue successfully crossing the chronic total occlusion.
So within the course of the CTO, if you have gone subintimal and then re-entered, I mean, that can happen a few times. It may not be just a straight line course. What is your strategy in those cases, and how far this particular technology helps you in navigating those cases?
So for the most part, once we identify that we go subintimal, we usually will pull the catheter back to where we're intraluminal and identify where we are, and then reposition the catheter to continue to allow us to go intraluminal rather than proceed subintimal.
Yeah, which means that the directional control of the catheter to navigate is fairly good. I have not personally used it. I don't know whether other callers on this conference have used it before, but I would invite anyone else in the audience to make a comment. I am familiar that maybe Dr. Prasad from
Subhash, I don't know. Can you hear me, or I don't know?
Yes, you are very clear, Anand. Please take it away.
Oh, okay. I've done about 4 cases actually in Austin with the device, and first of all, it's an excellent presentation. Second of all, the device is pretty remarkable in terms of the technology involved. I would say that this is still relatively first generation of image-guided crossing, in that it's not as maneuverable as we would like it to be, and I think there's further work that can be done. I'll defer to the speaker because of his experience with the device, but still think it can have some iterations in the future that make it more friendly in terms of moving the device around. It's also very little manual activity. It's a lot of it's automated. The actual crossing part of it is not like the kitty cat or the wildcat. It's sort of a automated motion, so you have to be confident where you're going based on the OCT image. I'm going to have to get off here in a minute, but I want to just leave with one other comment that I wanted this technology. Obviously, as physicians, we want all the new technology, but the big struggle we've had with our hospital is the cost of the device. Particularly if you fail to cross for whatever reason. you can't really get reimbursed for the OCT imaging aspect of the device, and obviously for a failed crossing, there's very little reimbursement. The maximal reimbursement would be if you cross true lumen and then are able to do atherectomy, of the device. So for that reason, I've had trouble with the hospital administration of trying to get this approved. It's quite expensive. There's a large capital purchase involved. So I'd love the speaker's comments on that as well at some point.
Dr. Cawich, I think Anand makes some great points, and I understand, I think you're going to respond briefly, but while you do, please also highlight for all of us who do not have adequate experience in this technology, what is the best case scenario or this ideal lesion where you choose to use this technology as a frontline crossing strategy?
So to answer your question first, Dr. Banerjee, my cases usually are not first case Ocelot. Usually most of these cases are guide wire failed cases. From what I've done is developed a nice referral pattern from other physicians that will attempt guide wire cases, and rather than send these cases to surgery, will send them for me to be able to use the OCT guidance. Because the cost is an issue, and then we realize that it's cheaper to pull a glide wire and a quick cross. And most of the time, the success rate using that is good, although the times that it doesn't work, as Dr. Prasad said, you don't get reimbursed for it. So a lot of these times, if you fail to cross a CTO, this is the technology, when the technology comes in and allows you. The other area is especially the popliteal area, where you don't want any stent placement, or you're trying to limit stent placement. So you want to try to cross intraluminal as much as possible to allow you to do atherectomy. And then this does allow you to visualize what you're crossing. You're able to identify whether there's a lot of calcium, a lot of fibrosis, a lot of thrombus, and allows you to also treat this chronic total occlusion in whichever atherectomy manner that you based on the imaging information that you receive while crossing. The catheter itself, the more of the catheter you have in the body, the less maneuverable it becomes. It seems to be that the CTO will grab onto the catheter since you're crossing, especially these long 40-centimeter CTOs. You tend to start having a little bit of problems with torqueability. There are obviously multiple catheters coming out that will address this, being able to put a better deflection on it. Calcium seems to want to deflect the catheter, so sometimes going across calcified segments can be difficult. They're coming out with a new catheter for that. And then as far as the cost, again, if you start this is mostly a referral. Most of my cases that I get are referrals from people that have failed. And so the hospital sees the benefit in having this technology available for those cases where we've not been able to cross on the first attempt.
Very good. Well, thank you, Dr. Cawich. That is, I think, the most common situations where we use specialized technologies, and I really appreciate you laying it out in such great depth. Again, I think I invite each one of you to log in the future webcast. I hope you all have liked it. This is a phenomenal presentation on some new technology that we look forward to. I hope, Dr. Cawich, you have enjoyed presenting it to our audiences and the interaction. I also invite you to participate in the XLPAD registry, which is probably going to start at your center very, very soon. Dr. Rodriguez is nearly done with most of the paperwork. We are in the process of getting final IRB approvals. So please do log into the website, xlpad.org, and the recording of this presentation will be posted. Dr. Cawich also and Dr. Rodriguez, please share it widely with your colleagues and with your team members at your institution.
Thank you for having us, Dr. Banerjee.
Yeah, and I once again appreciate all of you joining in, and then thank you and goodbye till next month. Bye-bye.